Hello, everyone. As chair of this study and of this committee meeting, I'd like to welcome everyone. The task undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of task can be found on the project website. We would like to thank the sponsors of this study. The committee members are listed on the screen. We will not have each committee member introduce themselves in order to save time. I would like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. We are also inviting residents, family members, and nursing home staff to submit their stories and experiences. Today's webinar will be recorded and archived at the link shown on the screen. I want to note that this is an open, on-the-record session. Individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor. Please do note, however, that anyone can submit testimony or other materials to the committee at any time, and these documents will be placed into the committee's public access file. You can submit this information through the project website. Today's webinar will hear the state survey perspective. We have given our speaker only 10 minutes for their remarks. I kindly ask the speaker to be respectful of this time limit so that we have ample time for discussion with the committee members. We are very grateful to have our speaker join us, and I would now like to introduce Polly Weaver. Her full bio is available in our briefing book. She is the State Operations Director for Healthcare Management Solutions. Thank you so much for being with us today.
Thank you very much. I appreciate that. And I appreciate the opportunity to spend a few moments with you all and share the perspective of a state survey agency director, actually a former state survey agency director, on the nursing home survey process. I was the state survey director for the state of Florida for over 20 years. And when I retired from the state of Florida, I went to work for Healthcare Management Solutions, and I'm the state operations director there, working with states and assisting them with achieving performance improvement initiatives, completing and implementing those initiatives to improve their internal and CMS performance expectation results. So the federal nursing home survey process has undergone several iterations over the years. The quality indicator survey process, which we fondly called QIS, was released in 2007 and was the first electronic-based data-driven nursing home survey process. The QIS, though, was not utilized by all states. Some states continue to use the paper-driven traditional survey process. Survey agencies that had utilized QIS and had implemented had noticed in some cases that the QIS took more time than what they were accustomed to with the traditional process, and certainly that raised concerns for resource implications. They also noted that there sometimes was difficulty with surveyors understanding how or when to pursue concerns that they identified during survey when those concerns weren't already included in that QIS algorithm that was used to base that data-driven, as I mentioned, survey process. So in 2015, CMS released a report that was titled Assessment of the Nursing Home Survey Processes, Current Trends, and Future Prospects for Survey Improvements. Those findings, one of the key findings that they noticed from that review was clearly there were resource implications for CMS as well as state survey agencies, depending on which process was implemented by the states. And CMS then also had to maintain training opportunities for two separate and distinct survey processes, and had to maintain staff that were capable of providing guidance to the state survey agencies on both survey processes. So managing and maintaining that expertise certainly was a burden to CMS, and then having a bifurcated staff and surveyor training program was also burdensome for both CMS and the state survey agencies. The review also noticed, though, there were good parts of both survey processes. So there was a need then to leverage the positives from both of those processes to come up with a process that would maximize efficiencies by identifying a facility's compliance with requirements for participation as quickly as possible, and leveraging emerging technologies to increase a surveyor's ability to navigate a large volume of information while still allowing for flexibility to address certain situations identified on the fly, if you will. So in 2017, CMS launched the current long-term care survey process, and all states were trained on that single process, on the implementation of that particular process. The LTCSP is also an automated process, and it reflects pertinent components of both the traditional and the QIS survey processes. Surveyors conduct in-depth investigation into areas of concern using the critical element pathways and interpretive guidance similar to the old QIS process. But again, there are certain flexibilities that are also built into this process that then mimic to some degree the traditional process. Understanding the dynamics of communication along with active listening, observing and interpreting nonverbal cues, and documenting what is heard and seen during the investigation can be some of the most overwhelming components of this and really any survey process that the surveyors must contend with. But I would have to say that a key issue that hasn't been resolved, even with the current long-term care survey process, or LTCSP, is the time it truly takes a surveyor to conduct a nursing home survey, coupled with turnaround times that must be met for the state agency to be in compliance with performance expectations. Based on data available in the CMS Quality Certification and Oversight Reports, or QCOR online data source, in federal fiscal year 2019, average on-site survey hours for nursing home recertification health surveys performed by the state agencies in the various CMS regional locations varied from a low of 106.8 hours in the CMS Chicago region to a high of 170.5 hours in the CMS Seattle region. So this would be the average number of survey hours that were devoted to nursing home surveys in the given states. Shorter survey hours certainly do not always reflect efficient implementation of the survey process, and likewise, longer survey hours do not necessarily reflect a better survey. The differences, though, certainly suggest a variation in the process or perhaps surveyor expertise in place nationally. Certainly, when surveyors rush through the process or simply fail to thoroughly investigate areas of concern, providers do not correct the non-compliance and they're not held accountable. National survey variation has several but related causes. For example, although the current survey process is structured with very specific guidance for the surveyors to follow, the process was designed to provide flexibility to enable surveyors to pursue concerns identified during the survey. Even with the guidance, though, surveyors must use professional judgment when making the compliance determination. This human factor does not negate the consistency that the process is designed to foster, but it certainly does challenge CMS and the state survey agencies to ensure staff are adequately trained on the regulations, the survey process, and relevant guidance. Additionally, state agencies do not have consistent surveyor training processes. Some state agencies rely on web-based training provided by CMS without providing effective precepting and support for newly hired surveyors. Then once trained, there is not a consistent process for identifying training needs for existing staff and providing that focused training in the state agencies. Effective surveyor training is a key area that state agencies need to tackle to ensure that the survey teams are equipped to implement the survey process accurately and consistently. As I said earlier, state agencies do not always have a formalized training program designed to identify areas needing additional training. This is particularly challenging for new surveyors who do not have a background in nursing home care or other clinical expertise. So I think it's important for the committee to realize that there is not a certain standard of minimum qualification requirements for surveyors. States have designated positions that they identify as surveyor positions, and so they hire staff into those particular positions. Some states hire only nurses. Some states will have a mix of nurses and what they may refer to as a generalist or have other identifiers. Then those generalists or non-nurses might be dietitians, might be social workers, and might be a generalist that has even no background in either nursing home care or even any clinical expertise, which is then why the training becomes so important. So if there's not an established training program, then those surveyors are certainly are at a loss very often as to how to conduct the surveys, even with the web-based training that CMS does offer. States also may lack an effective quality assurance program to internally identify surveys that were not appropriately completed or the report was not accurately written. Best practice would utilize the findings from QA reviews to identify trends within the state agency where training opportunities should focus. Of course, training and QA programs require resources that some state agencies simply do not have. Additionally, turnover increases the burden on effective surveyor training and workload completion. The turnover is often a result of lower surveyor salaries and extensive travel required to do the job. And the pandemic has certainly exacerbated the problem of surveyor turnover. During the pandemic, some of the states, because they were not currently surveying, their staff were diverted to public health functions. And in interactions that I had with several states, they shared that their nurses that were being utilized for public health use or public health functions had said they weren't public health nurses anymore. And so they opted to resign or retire, depending on where they were in their career, to look for other opportunities. But I have to say, just from my experience as a personal experience as a state survey agency director, effective recruitment and retention of surveyors was a significant challenge for me. As I mentioned earlier, people leave surveyor positions often as a result of the lower pay scale, coupled by the extensive travel that is required of surveyors. In Florida, we had a combined program. But to maintain our workload and ensure that we were timely completing our workload, surveyors might have to travel the state to complete that work. Some states have similar arrangements as well. And so they may be centrally located and their surveyors cover the entire state. Going back to Florida, we were arranged in 8 regional offices or district offices, field offices. So the surveyors primarily worked in those offices, but if they were needed in other parts of the state, then that's where they surveyed. And some of those regions could be pretty big. So nursing home surveys often require, they're typically a 4-day survey, give or take. And that would often require overnight travel. And sometimes, again, the surveyors are, they're spending the night away from home a lot, and depending on their personal situation, that isn't something that's always delightful for them to do because they're away from their families. And some of us, as I mentioned earlier, have the obligation or the privilege actually of caring for elder parents. And so it's that sandwich generation in a way of trying to care for perhaps grandchildren or children, and then aging parents. So it can be certainly stressful for the surveyors to deal with all of the travel. Also, one of the challenges as well is that the LTCSP is a very complex survey process that requires some level of computer expertise that, as hard as it is to believe in this day and time, is not a given when applicants indicate an interest in being a surveyor. Therefore, to ensure that new hires are ready to step into the survey process, states need to invest in basic computer skills training to facilitate success. This is across the board with various backgrounds. We have seen cases where nursing surveyors are very challenged using the computer processes, and non-nurses are challenged using the computer processes. So we had a basic computer skills work that we did. We had a basic test that we gave them just to see where they were, and did they know more than finding the on and off button, for instance, and if they were able to actually navigate the computer effectively, so that they would be effective in using a computer-based survey program. Effective utilization of available data is another challenge for state agency leadership. The current federal data systems are designed more to be a repository for survey data rather than a means of producing reports to monitor workload completion and other quality improvement initiatives. Reports currently available are not particularly user-friendly or limited in the scope of data that would be utilized for this purpose. Therefore, to have an effective QA/QI program, state agencies need to develop reports, and those resources, that staff that are needed to complete that work, simply may not be available. And another area that would be important for the committee to be aware of is that every state has their own limitations with how they must manage their budget and how they are able to get funding through their budget. And CMS does pay the states for the work that is done under survey and certification on behalf of CMS. And if CMS increases funding, that is always a welcome opportunity. However, the states still have to the state survey agencies have to have spending authority to use that money. So they still have to get the permission most often from their legislators or their legislative body to be able to access that money that is provided. So there certainly are limitations, and those limitations vary with each state because the states have separate rules for how the budgets can be accessed and what the budget limitations might be within each state. So in closing, I would like to suggest also, in thinking about ways that the process could be improved in how to carry out the CMS expectations or the CMS survey process, that the opportunity for a risk-based survey schedule would assist states with lengthening the time between survey visits for a good performer that provides thorough, dependable incident reporting to the state agency. This would allow states to focus on providers who need extra survey attention. And this type of change would require a change to the law, but is something that has been suggested by states in the past and is worth considering. I would add, though, that utilization of a risk-based survey process or survey scheduling process to identify the good performers that can have a longer interval between surveys would be dependent on a survey process that people had confidence in, that was being accurately and consistently implemented within a state as well as among the states. So that concludes my prepared comments that I wanted to share with you this morning, and I'll turn it over and see if you have any questions.
Thank you so much, Ms. Weaver, for your remarks. And as you mentioned, we will now move into questions and comments from the committee. So please use the raise hand function if you have anything to ask, and you can press Alt and Y on your keyboard if you can't find the button. Dr. Stevenson, you're up first.
Thanks very much for that great presentation. I mean, it really drives home that the challenges here are multidimensional. It's not just resources, it goes beyond that. I'm intrigued, by the last point that you raised, which, is around, the risk-based or the more targeted survey activities. And as you know, like identifying the high performers is the contentious part. It's not as contentious to identify poor performers and survey them more often. But can you talk a little bit about, whether it's incident reporting, complaint response, things like that, and also accountability to ensure that confidence exists if you go that route?
Well, in considering how this type of process could be implemented, I think depending on or looking at how the facilities, how the providers submit their incident reports, how thorough are their reports. If the state has to pursue the provider, because they have to file incident reports, they must file facility reported incidents that where there are incidents of abuse, neglect, basically exploitation, maltreatment of the residents in the nursing home that meet this very specific criteria. Very often the states get reports and they're very limited in scope. So it's very difficult to read the report and determine truly what happened, what was identified by the facility, and what have they done to address the problem. So when you have performers or have nursing homes that do provide a thorough report to actually indicate this is what we did, and you have confidence that they are currently in compliance, and with some experience with having conducted complaint investigations and reviews of those incidents to determine that yes, in fact, they did implement what they said they implemented, then you have a confidence that this is a nursing home that I placed my mother in, that they are following up on the concerns that are identified. Let's face it, the best performer is going to have incidents from time to time because we're dealing with people that are sometimes unpredictable, whether it's the resident or the staff. But the facility's response in addressing those concerns and being prepared for those concerns really can establish a criteria that can be, developed on a score, a scoring system as to, having a consistent rubric for how the facilities address, identify, self-identify, and then address those concerns. I do think one of the things that CMS thought was a great idea for nursing homes that has challenged this process is the ability to cite for past noncompliance. So when the facility has had an issue of noncompliance that has corrected it, and for it to qualify as past noncompliance, it has to be completely corrected when the surveyors walk in the door. Nursing homes are a little nervous about that because they're being penalized for having identified and corrected a problem still, even though it's completely in compliance at the time. And when that provision first came out, it was really, kind of centered more towards immediate jeopardy type situations, those extreme situations, but the guidance does not specify that now. So some states could actually go all the way down to a DEF, a low level deficiency, and cite the facility for this past noncompliance, again, even though it's completely corrected. So that always kind of creates that challenge of, okay, if I report this, they're going to come in and they're going to resurvey me. And so I'm going to, I'm just shooting myself in the foot, so to speak, by identifying this and reporting on it. So navigating that system with the providers and developing a process for, in my opinion, reserving past noncompliance for those egregious situations, mostly immediate jeopardy. And that's primarily how we used it in Florida, was for immediate jeopardy, so that the facility was not penalized for every concern of noncompliance, even though currently correct. And keeping in mind, nursing homes, there's all of the providers that CMS regulates do not have the concern of past noncompliance. A hospital, for instance, does not, unless it's an EMTALA violation. So nursing homes are kind of a different, they're kind of set apart in how the regulations are implemented for them, and it has a good side to bad side, like everything else does. But I think that was an unintended consequence of the past noncompliance provision, because it does kind of cause some providers to hesitate in providing those reports.
Thank you.
You're welcome.
Dr. Ercik.
Thank you so much. That was a great presentation. It's a fascinating process for all of us who are involved in nursing homes. I was wondering if you could comment on, you know, we've heard testimony and read, you know, the survey is too extensive and it's too punitive. And then from other folks, we've heard it's not punitive enough, it's not hard enough. How do you advise state surveyors to, if you will, strike a balance between not adversarial necessarily, but you know, you have an important role in ensuring that bad actors and bad care does not occur. On the other hand, is there a balance, and how do you reach that balance?
Well, I think one thing is teaching the surveyors to assume compliance. They should not enter a survey assuming that the facility is not compliant. In other words, don't look till you find it. So and when you go to nursing, you know, when you think about nursing homes again for a recertification survey, that is a pretty defined process. So if they let that process flow, they should be able to identify the non-compliance in a balanced way, and they should be able to document it. But the problem with that is the surveyors are not trained consistently nationally. So where one might think that the regulations don't go far enough, I'm not so sure it's a problem with the regulation. It's a problem with the implementation of the process, because we do find, you know, that surveyors do rush through. They're you know, we're going to do this survey in X number of days, and you can tell that again looking at that Q-Core data. I don't know how you can do a nursing home survey in 2.5 days. I just don't know how you can do that unless it's a 30-bed facility, and that might be pushing it, because there's still a lot of things to look at. So I think the state leadership is obligated to monitor the work that their staff are doing to see if what they're doing is reasonable. The data in and of itself doesn't say anything. They really need to look behind that data to say, are we an outlier, and why might that be? So, I think though, establishing that relationship with the surveyor, so they understand that their job is to assess compliance, and while again not look until you find something, you know, and sometimes that comes from hiring the right staff right at the beginning, because I can tell you when we would get staff, you know, and I obviously wasn't responsible for hiring everybody statewide in Florida, but we would have discussions about the applicants sometimes. And when you had somebody who said, oh, I want to be a nursing home surveyor because I had a horrible experience with my mother and I'm getting them. And okay, well, thank you for your interest. And, you know, you just kind of went through that pile a little bit deeper. So you want to have that, you need to have that right combination, and having the right person and providing the tools that they need and the training they need, but then the oversight, trust but verify. So have your QA program and look to see what are they doing? Are they completing the process? And especially complaints. If you have teams that would not substantiate a complaint on a sunny day, I can't believe all the complainants in the state are not, you know, providing valid complaints. So why are you not? Are you thoroughly investigating that complaint? Are you looking at what you need to be looking at? Are you even looking at the right regulation? Are you going in at the right time? Was the issue occurring on the midnight shift? Then don't go in at 10 a.m. You know, and those are expectations that CMS includes in their review, but the state should be including that in their internal reviews as well, and then, you know, correcting that ship as they're moving through the process, so that they can have a better response to, is the survey process valid, or is the problem with the implementation of the one we have?
We're coming up at the end of our time, but we do want to give the committee a chance to ask their questions if you're able to stay with us, Ms. Weaver. So that would be great. We have Assistant Secretary Greenlee and then Dr. Stevenson.
Thank you for your overview, Polly. I'm Kathy Greenlee. 15 years ago, I was in charge of survey in the state of Kansas, and Kansas was one of the early QIS states. and it was more expensive, as you talked about earlier. Will you talk about closing a facility and whether or not the states have the tools and the support from CMS? I mean, we have talked about a lot in the committee, of course, about the better performers, like you're talking about, risk-based surveys. We've talked about the special focus facilities, but the end of the road for a special focus facility could be their termination of their license in the state and closure of the building, which is a terrible impact on residents, I understand. But have you been through that process, and do states have what they need to ultimately get the real bad actors out of the state?
Well, I've definitely been through that process. It is a painful process, and from a lot of respects, because the relocation of residents, it is their home, and that's an important observation, because I would get calls from family members that would say, "You can't make my mother leave. This is her home." Well, she's not safe there. That is the balance that you have to strike. As far as resources are concerned, it's really a two-step process. So the certification, the ending of certification is going to be based on the facility's ability to come into compliance within the mandated timeframes. 23 days from the exit date for immediate jeopardy, and 6 months, depending on that very complicated enforcement cycle, for non-immediate jeopardy non-compliance in a nursing home. So if the facility does not come into compliance, theoretically they are in that time frame. They should be terminated. The complication comes in because, of course, the facility can file for hearings, and they have recourse, and working through that process then often drags out or extends the time frame for the actual closure of the facility. Once the closure occurs, really the closure is on the state to complete. The CMS provides, our experience, CMS provided guidance to the states from a certification perspective, but the state had to implement the state's resources for the relocation of residents, the coordination with the ombudsman, the coordination with Medicaid, the continuation of payment, the ability to continue payment for 30 days after the termination date to provide for the safe relocation of residents, but then finding the placement for some very hard to place residents sometimes as well. So the support we got from CMS to help us locate residents or facilities with certain expertise was helpful, but the actual boots on the ground, the actual work had to be accomplished within the state. And then the state license is a completely separate process. So certification might be ended, and the facility maintains their state license. So they could theoretically continue to operate under private pay, or try to sell, and then come back in, most likely under a new provider number, under a new ownership.
Thank you.
You're welcome.
Dr. Rance, I saw that you had your hand raised. I don't know if you still wanted to ask your question.
Well, I was afraid we had run out of time.
Well, maybe we could be brief, but please go ahead.
Okay. Thank you for this presentation. It's been very helpful. The follow-up question that I had was, based on your experience with this process, if you could change a thing or two that you really think would impact the quality of care and the quality of life of nursing home residents and improve upon the survey process, what would that be?
I truly think that if we could come up with a risk-based approach so that the states aren't spending so much time on performers that they may not be deficiency-free, but they're good performers and they are addressing their issues as they arise, and then spend more time with those problem performers, that truly would provide, I think that would put the focus where it needs to be. I think the other point to consider as well, though, is really stepping back and looking at how we're able to prepare our surveyors so that they are confident when they are conducting those surveys, and really understanding their role as a surveyor, and how they how they can complete that work, and understanding once they complete the training, they're not an efficient surveyor, they're trained. So with, it takes time for a surveyor to really, just like all of us, whatever work we've done, it took us a while to feel like we were good at it. So I think getting them to understand so that the states can retain those staff that they're investing so much money into train would be very helpful. I found it very helpful from my perspective also to partner. I partnered with the associations. I provided, I did a lot of talk. That's why Ed said what he said. My mother thought it was great that I got paid to talk finally. But to be able to interact with the providers so that the regulator is a regulator. It's not, we're not collaborating when we're in there doing a survey. It is, the point is to identify compliance, but there's the forum for providing education to providers and to their staff, I think is just an opportunity that is often missed. One of the things that we were able to do was partner with the QIO and go into nursing homes when we were having such a push for reducing antipsychotic use in nursing homes. We had some nursing homes that just always seemed to be the poorest performers in that respect. So they allowed us to come in and provide training to their staff, because I noticed when I would talk at the association meetings, I met the administrators and the CEOs and maybe the DON. I didn't meet the caregiving staff. So we went into the nursing and they brought everybody in. We did 2 sessions and we had housekeepers, we had maintenance people. And, I had a mother who had dementia until her death. And so I had a family perspective as well as the regulatory perspective, and the poor QIO person taught data. But we were able to get in there and actually, I think make a difference in those facilities, because the goal was to let the caregiving staff understand what they needed to do better. And I talked a lot about training in the states for implementing the survey process leaves a bit to be desired. Quite honestly, the training in the nursing homes for the caregiving staff leaves a bit to be desired, because I don't think the direct care staff really understand what it is they need to do to truly care for a resident. And especially when you're thinking about CNAs, and they're not a high pay scale, and they aren't always equipped to deal, especially with residents with dementia. It's one thing if you're in a facility where everybody's pretty self-sufficient, and then you're dealing with someone with dementia who may strike out, who may say things that are inappropriate, and understanding how to respond to that is a challenge, is certainly a challenge. So I think that is an area that has been woefully ill-addressed, and I think to some degree that's because the nursing homes have just chosen, they just have chosen not to really put that focus there. In a lot of cases, it's the same thing, it's resources. You still have to pay them to come in. They're not providing care, they're sitting in training. What do I bill for? So.
Thank you.
You're welcome.
Thank you so much. I think we will turn it back to Dr. Farrell to close us out.
Thank you very much. We really appreciate that valuable presentation. It's so informative for our committee. We really want to thank Ms. Weaver for being with us. And again, as a reminder, we welcome anyone to submit resident, family, or nursing home staff experiences, as well as also a reminder that today's webinar is recorded and available on our webpage. We will now take a 5-minute break, and so the committee will be reconvening in a closed session through the new Zoom link in 5 minutes. Thank you, everyone.
Thank you.